Now, while discussing about the posterior abdominal wall, I hope you remember I have shown you the diaphragm, respiratory diaphragm. Okay, I have shown you the diagram also. Then, in brief, we have discussed about the diaphragm, but today we will be discussing in detail about the respiratory diaphragm. I hope everyone you have seen the respiratory diaphragm in dissection hall in the cadaver. You have seen, okay. What you have studied about the diaphragm? Have you studied anything about the diaphragm? What exactly you have studied? We know that it is a partition between the thorax and the abdomen. What else do you know about the diaphragm? It is made up of what? Diaphragm is made up of what? Muscles. Anyone in the class, diaphragm is made up of what? See, most of the part, actually diaphragm is a skeletal muscle. Okay, diaphragm is a skeletal muscle. That means most of the part is made up of skeletal muscle fibers. Okay, so if a skeletal muscle is there, that means it will be having origin, it will be having insertion, then actions will be there, nerve supply, blood supply. Okay, all those points will be there. Okay, so diaphragm is a skeletal muscle. Please keep that in mind. Okay. So, if any skeletal muscle is there, the way you have studied the skeletal muscles of upper limb and lower limb, in the similar way we have to study. Okay. So, diaphragm is a skeletal muscle. Now, the skeletal muscle, the way you have studied about the skeletal muscle, I am not discussing about the microscopic structure. Okay, the skeletal muscles which you have studied in upper limb, which you have studied in lower limb, in the similar way we have to study about the diaphragm. Okay, so first will be the origin, then insertion, okay, this is how we are going to discuss about the diaphragm, followed by the applied part. Okay, followed by the applied part. And today we'll be discussing a very important and interesting phenomena. Okay, very important and interesting phenomena. Okay, now what is that phenomena? For example, we know that the skeletal muscle fibers which are there in our body, okay, they are prone to fatigue. Okay, they are prone to fatigue. But just imagine you are breathing continuously, and which is the chief muscle of respiration? Diaphragm. Does it get fatigue? No. Why? It is a skeletal muscle only. If you see the thickness of the diaphragm, it is approximately 2 to 4 millimeter. Not thick muscle. Okay, but still it is not getting fatigue. Continuously you can breathe. Have you thought why it is like this? For that, a very interesting phenomena is there, and that is called as Orwelli phenomena. Have you heard about it, anyone? Orwelli phenomena? I don't think so you have heard about it. Okay, so it is a speciality of the diaphragm, and it comes from the nerve supply of the diaphragm. Okay, now these are the points under which we will be discussing about the diaphragm. So any skeletal muscle origin is there, then insertion will be there, and we know that insertion part is tendinous in nature. Okay, already you have studied, if you remember, about the muscles of the upper limb and lower limb. Okay, followed by the actions. So diaphragm is having actions in various regions. For example, it is having some important actions in the thoracic cavity, it is having actions in the abdominal cavity also. Okay, next it is also having some important action, okay, through which various structures are passing. Okay, and ultimately the nerve supply and blood supply. Okay, so we'll begin with the respiratory diaphragm. though you have seen the respiratory diaphragm, can anyone tell me what is the shape? How does it look like? Dome shaped. Okay, very good. It is dome shaped. Okay, so it is dome shaped. Along with that, it is muscular aponeurotic partition. Okay, between the thorax and the abdomen. Dome shaped muscular aponeurotic partition between the thorax and the abdomen. Okay. Now, if you see the respiratory diaphragm, it is forming the roof of the abdomen. So already we have discussed the boundaries of the abdominal cavity. At that time I have showed you the roof. Okay, we have seen the diaphragm is forming the roof of the abdominal cavity. Okay, now if you see the thoracic surface of the diaphragm, okay, so the diaphragm is having thoracic surface also, it is having an abdominal surface also. So if you see the thoracic surface, how they are situated in the form of dome shaped. Okay, now and what is the shape? These are convex shaped dome. Together it is called as cupolae. Okay, together it is called as cupolae. The thoracic surface of the diaphragm, okay, right and left side, and the central part is depressed. Okay, so the summits of the convexities are called as cupolae. That means the highest point of the convexity. Okay, right convexity is there, left convexity is there. So the highest point of the convexities are called as cupolae. Okay. Now the right cupolae is slightly higher, as you can see, right cupolae is slightly higher than the left due to the presence of the liver, because just below the right dome, what is situated? Liver is situated. Okay, which is a huge organ. That's why the right cupolae is slightly higher than the left one. Next, if you see the peripheral part of the diaphragm, mostly it is made up of muscle. Which muscle is there? Striated muscle or skeletal muscle. Peripheral part of the diaphragm, mostly it is made up of skeletal muscle or striated muscle. And what about the central part? Central part is tendinous in nature. Okay, that means the fibers, they are converging towards the center. Okay, and it is inserting in the center. That's why the central part which is there, it is a depressed area, and along with that it is tendinous in nature. Okay, that means it is completely made up of tendon. That is the speciality of the diaphragm. Okay, next if you see the origin of the diaphragm, okay, so you have to divide the origin of the diaphragm. Okay, how you will divide the origin of the diaphragm? Origin from anterior aspect, origin from lateral aspect, and origin from posterior aspect. Like this you have to divide it in order to understand the origin of the diaphragm. Okay, so in diaphragm how many origins are there? 3 origins are there. How you will divide it? From anterior aspect, lateral aspect, and posterior aspect. This is how you have to divide it. Okay, now from the anterior aspect, the sternal origin, lateral aspect, costal and costal cartilages are there, from which the origin is taking place, and posteriorly is the lumbar vertebra, from which it is arising. Okay, I hope you have studied about lumbar vertebra, everyone. Okay, so you have studied typical, atypical lumbar vertebra, about the parts of the lumbar vertebra. Along with the attachments also you have studied. I know you have studied. Okay, so so you will not be having any problem in understanding about the origin of the diaphragm from the lumbar vertebra. Okay, now from where the sternal part arises, have you seen the sternum? How many parts are there? 3 parts. What are they? Manubrium, body, and xiphoid process. Okay, so in this case, from where the fibers are arising, it is arising from posterior aspect of the xiphoid process. Okay, 2 fleshy slips are there, from which the diaphragm is arising from the posterior aspect of the xiphoid process. Okay, so as you can see, the sternal part arises by 2 fleshy slips from the posterior aspect of the xiphoid process. Okay, next, so that is the anterior origin. From anterior origin, you have to go laterally on both the sides. Okay, laterally means both the side, right side also, left side also. So laterally, what do you think? What will be there? Ribs are there. Okay, so it is taking origin from the ribs also. Along with that, the adjacent costal cartilages. Okay, it is arising from ribs along with the adjacent costal cartilages. So the costal part, you can see, arises from the inner surface of the cartilages and the adjacent part of the inner surface of the lower ribs, lower 6 ribs from each side. Now when it is arising from the lower 6 ribs of each side, it is interdigitating with the transversus abdominis muscle. Okay, because we know the transversus abdominis muscle is also arising from that part. So it will be interdigitating with the muscle fibers of the transversus abdominis. Okay, this is how the origin takes place, from the ribs as well as the costal cartilages. Which ribs? Lower 6 ribs, that also inner surface. Next, the lumbar one. So this part arises from the medial and lateral lumbocostal arch. Okay, very important. And from the lumbar vertebra by right and left crura. Okay, so if you see the lumbar origin, first of all, 2 arches are there. Okay, that is the medial and lateral lumbocostal arch, or also called as medial arcuate ligament or lateral arcuate ligament. Okay, these are the areas from which it is arising posteriorly. Along with that, it also arises from the body of the lumbar vertebra. Now, the way it is arising from the body of the lumbar vertebra, it is in the form of crus. So 2 crus are there, right crus and left crus. That's why they are called as crura of the diaphragm. Okay. Now here you can see the diagram. In this diagram, can you see the origin of the diaphragm? Now, what is this? This is the xiphoid process. Okay, so you can see it is arising from the xiphoid process, and you can see it is arising from the lower 6 ribs as well as the costal cartilages. Okay, and then it is going posteriorly. Now posteriorly you are getting the lumbar vertebra. Can you see the lumbar vertebra? Okay, so you can see 2 crura are there. This is the right crus, this is the left crus. Okay, see, right crus and left crus. Right crus is larger, heavier, okay, as compared to the left one, and it is longer also, the right crus. So here you can see they are arising from the lumbar vertebra, and along with that you can also see the medial arcuate ligament, and you can see the lateral arcuate ligament. Anyone, have you heard about this? What is medial and lateral arcuate ligaments? They are also called as medial and lateral lumbocostal arches. No? It's okay, we'll discuss about this. Okay. So see, this is the way it is arising. Okay, so we are discussing about the origin of the diaphragm. How many origins are there of the diaphragm? 3 origins are there. How you have to study about those 3 origins? You have to go from anterior aspect, then you have to see the lateral origin, and then you have to go posteriorly. Okay, anteriorly which part is there? Xiphoid process, from the posterior aspect of the xiphoid process, as it is shown in the diagram. What about the lateral aspect? Laterally it is taking origin from the lower 6 inner surface of the lower 6 ribs along with the adjacent costal cartilages. Okay, and if you go posteriorly, 2 things are there. What are these? These are the medial and lateral lumbocostal arches. We'll discuss what are those arches. Along with that, it arises from the 2 crura, or right crus and left crus, from the lumbar vertebra. Okay, right crus is longer, heavier as compared to the left one. Okay, as you can see in the diagram. Now, what exactly are these medial and lateral lumbocostal arches? Okay, so these are nothing but they are also called as medial and lateral arcuate ligament. Okay, they are also called as medial and lateral arcuate ligament. These are tendinous arch, okay, in the fascia covering the upper part of the psoas major muscle. Okay, so the medial arcuate ligament, if you see the medial arcuate ligament, it is the tendinous arch over the fascia covering the upper part of the psoas major muscle. Okay, so the upper part of the psoas major muscle, the fascia which is covering it, it is getting thickened to form a arc-like structure, and that is called as medial arcuate ligament. Okay. Next, if you see the attachment of this medial arcuate ligament, though it is getting thickened, so it must have some attachments. So these attachments is attached to the body of first lumbar vertebra, and it is continuous with the lateral margin of the corresponding crus. Okay, so what is the attachment? First attachment is the body of the first lumbar vertebra, medially. Now what is the lateral attachment? Okay, so you know that body is situated medially, transverse process is situated laterally. If you have studied the lumbar vertebra or any of the vertebra, body kahan pe rehta hai? Body is situated in the midline, right? And on the both the side we are getting the transverse processes. Now there may be some differences in the transverse process of thoracic or lumbar vertebra, but transverse processes are situated mostly laterally or posterolaterally. Okay, so laterally where it will be attached? It will attach to the front of the transverse process of first lumbar vertebra. Okay, that is the attachment of the medial arcuate ligament, which is nothing but the thickening of the fascia, which is covering the upper part of the psoas major muscle. Okay. Next is the lateral lumbocostal arch, or also called as lateral arcuate ligament. Same, it is also a tendinous arch produced by the fascia, which is covering the upper part of the quadratus lumborum muscle. If you remember the muscles of the posterior abdominal wall, which we have discussed earlier, okay, I am talking about those muscles, and fascia, which is covering the upper aspect of those muscles, okay, they get thickened to form those ligaments, okay, which is tendinous in nature. Next, if you see the attachment, medially it attached to the front of the transverse process of the first lumbar vertebra, okay, and laterally where it is attached to the lower border of the 12th rib, okay. Now for your reference, you can see the diagram. See the medial arcuate ligament, okay, and you can see the lateral arcuate ligament, and see the attachment. It is attaching into the 12th rib, okay. So these are also important because these are the parts from which the posterior origin of the diaphragm is taking place, okay. So you have to mention whenever you are writing about the, or you are discussing about the origin of the diaphragm, you have to mention about the posterior origin also. And in posterior origin, as I say, two parts are there, from those medial and lateral lumbocostal arches and from the lumbar vertebra, bodies of the lumbar vertebra, by two crura, right and left crus. Okay, next the right crus, as I said, it is larger, stronger as compared to the left crus. Why? Because it has to pull down the liver during the inspiration. Okay, I hope you have studied the process of inspiration. Okay, how the air is going in, how it is coming out, what is the movement of the diaphragm, what are the movements of the ribs, what is pump handle movement, what is bucket handle movement. Already you have studied. Okay, so I hope you are having the concept. Now, if you see the right crus and left crus, okay, it arises from the anterior surface of the bodies of upper three lumbar vertebrae. Okay, so if you see the right crus, it arises from the anterolateral surface of the bodies of upper three lumbar vertebrae. What is the meaning of this? That means first, second, and third lumbar vertebrae. Okay, from the lateral aspect of the body of first, second, and third lumbar vertebrae. Okay, intervening the intervertebral disc. The right crus is giving attachment to the suspensory ligament of duodenojejunal flexor. Anyone, do you remember what is this duodenojejunal flexor? Sorry, it is a ligament of duodenojejunal flexor. What is this? What is the ligament of the duodenojejunal flexor? It is also called as ligament of It, which we have discussed, I think, last week. Okay, so the terminal part of the duodenum and the proximal part of the jejunum, it is supported by a ligament. It is called as ligaments of It or suspensory ligament. Okay, now that one part is attached to the flexor and another part is attached to the right crus of the diaphragm posteriorly. So this is how it is supporting the flexor. Okay. Next, if you see the left crus, it arises from the upper two lumbar vertebrae. Okay, corresponding side of the upper two lumbar vertebrae. That is L1 and L2. In case of right crus, L1, L2, L3. Okay, but in case of left crus, only L1 and L2. This suggests that the right one is longer as compared to the left one. Now, if you see the left crus is attached to the bare area of the posterior surface of the cardiac end of the stomach by gastrophrenic ligament. I hope you have studied the stomach. We know that stomach is mostly intraperitoneal, but there is a small area on the posterior surface of the stomach near the cardiac end, which is bare area. Why? Because it is attached to the diaphragm. So this is the attachment. Okay, how it is attached? With the help of gastrophrenic ligament. Okay, so these are the points from which you can expect MCQs. Okay, these are the points from which you can expect MCQ. Next, if you see, so we have seen the medial and lateral arcuate ligament, and then we have seen the origin of the right crus and left crus. Okay. Next, if you see the median arcuate ligament, so two things are there. One is medial and another one is median. I hope you know the difference. What is medial and what is median? Median will be situated in the midline. Okay. So the medial arcuate ligaments which are there. Okay. Now here you can see medial margins of the true crura. Okay, medial margins of the true crura, both the right one and the left one, the medial margin, okay, they are forming a tendinous arch in front of the aorta or in front of the aortic opening, and that is called as median arcuate ligament. Let me show you the diagram. Okay, now here you can see this is the right crus. You can see the origin of the right crus and you can see the origin of the left crus. So in between both the crura, a tendinous arch is there. Okay, a tendinous arch is there in between both the crura, which is overlying the aortic opening. This is the aortic opening, and this tendinous arch which is formed between the medial margins of both the crura, these are called as median arcuate ligament. Okay, median arcuate ligament. Two separate things. Medial one is different, median one is different. Okay, don't get confused. So that is all about the origin of the diaphragm. Okay, now here you can see, so this is the anterior aspect, this is the posterior aspect. So this is the anterior origin. Now this is the lateral origin. Okay, this is the lateral origin, and you can see this is the posterior origin. And posterior origin, first of all, you can see what is this? This is the medial arcuate ligament. This is the lateral arcuate ligament on both the sides. Okay. Next, you can see this is the right crus and this is the left crus. Now, in between the right crus and left crus, the medial margins, you can see a tendinous arch about the aortic opening. And what is this? This is also called as median arcuate ligament. Okay. So this is the origin. Okay. Next, after origin, what is the point? Next point, it is the insertion. Okay. Now, can you see the fibers? They are converging towards the center. Okay. The fibers from the periphery. So, as I said, on the peripheral aspect, it is made up of striated muscle or skeletal muscle. So, this entire part, peripheral part, it is made up of what? It is made up of skeletal muscle. Okay. Now, from there, the fibers are converging towards the center. Okay. To get it inserted, and that particular part is called as central tendon of the diaphragm. Okay, you can see the central tendon of the diaphragm. Now the insertion is not that easy, though the origin was complicated, so insertion is also not that easy. Some complications are there. Complication means some complicated structures are there. Okay. Now, as you can see the muscle fibers, okay, if you see the muscle fibers, circumferential origin is there. That means the origin which is taking place, okay, after that the muscle fibers, the way they are oriented, it is circumferential direction. Okay. First, the fibers will arch upwards and inwards to form the right and left dome. This is the direction of the fibers. Okay, how the fibers are going, as you can see, arching upwards and inwards. Okay, upwards and inwards to form the domes, right dome and left dome. Okay. Next, you can see right dome is higher, left dome is lower, already we have discussed. Next, the central tendon lies at the level of the lower end of the sternum, okay, at the level of 6 costal cartilage. This is the location of the central tendon of the diaphragm. Okay, this is the location of the central tendon of the diaphragm at the level of 6 costal cartilage. Now, all the fibers converge towards the central tendon for their insertion. So, from the periphery, the fibers, how they are arranged in circumferential fashion. Okay, then you have seen they are going upwards and inward to form the dome, and then ultimately they will converge at the center to form the central tendon of the diaphragm. Now, where the central tendon is located at the level of 6 costal cartilage. Okay. Next, the downward concavity of the dome is occupied by the liver, okay, that is on the right side, and on the left side you are getting the fundus of the stomach. Okay. Now, two domes are there, a right dome and left dome. As I said, right dome is higher as compared to the left one. Okay. So, below the right dome, what is situated? Liver is situated, and below the left dome, what is situated? Stomach is situated, fundus of the stomach. Okay. Now, this is a beautiful diagram, 3D diagram, where you can see the diaphragm from the anterior aspect. Okay. Now, which dome is this? This is the right dome. And which dome is this? This is the left dome. Okay. Now, here the stomach is removed so that you can see how the domes are situated. Okay. and this is the central tendon of the diaphragm. See the central tendon of the diaphragm. Okay, and as I said, right dome is higher as compared to the left one. Okay. Next is the insertion. Okay, so if origin is there, insertion will also be there. So the central insertion is in the form of central tendon of the diaphragm lies below the pericardium. Now you have studied the heart, you have seen pericardium. Okay, so it is situated below the pericardium and the pericardium is fused to it. Okay, जो central tendon होता है, the pericardium is fused to the central tendon of the diaphragm. Okay, that means you can say pericardium is lying on the central tendon of the diaphragm. Okay, now if you see the shape of the tendon, it is trilobar in shape. What is the shape of the tendon? It is trilobar in shape. That means it is having 3 leaflets. Okay, it is having 3 leaflets. As you can see, it is trilobar in shape, made up of 3 leaflets. Middle leaflet is there and right and left leaflet. Now if you see the shape of the middle leaflet, it is triangular in shape and the apex is directed towards the xiphoid process. Okay, the tendon of the diaphragm, central tendon where the fibers are converging, okay, for that insertion, it is situated at the level of 6 costal cartilage. Next, if you see the tendon, what is the shape? It is trilobar in shape, having 3 leaflets. One middle leaflet is there which is triangular in shape and 2 lateral leaflets are there, one on the right side and one on the left side. Okay, now those leaflets are tongue shaped. Okay, right and left leaflets are tongue shaped and curve laterally and backwards. This is the direction of the 2 leaflets. Okay, now left being little narrower than the right. Okay, left one is a bit narrower as compared to the right one. Now the central area consists of well-formed diagonal bends. These are also important. Okay, and these diagonal bends fan out. Okay, and decussate in front of the opening of the esophagus. Okay, so bands of fibers are there which decussate. Okay, now that decussation is taking place in front of the opening of the esophagus. Okay, so in that particular part, the opening of the esophagus is situated. Now here you can see the diagram. In this diagram you can see the insertion where the central tendon can be seen. Okay, so this is the central tendon of the diaphragm. In the central tendon, this is the middle part. As I said, it is trilobar. Trilobar means 3 leaflets are there. Okay? Now at the center, this is the middle leaflet, this is the right leaflet and this is the left leaflet. Okay, and here you can see a opening is there. Okay, so this particular opening is for esophagus. Okay, so these are the insertion of the diaphragm. Okay, next there are some openings in the diaphragm. Okay, because we know the diaphragm is separating the thoracic and the abdominal cavity. Now there are several structures which are going from thoracic cavity to the abdominal cavity, and there are some structures which are going from abdominal cavity to the thoracic cavity. Right? Can you name some structures which are ascending? Most of the structures are descending. We know that. Now, can you name some structures which are ascending? That means going from abdominal cavity to the thoracic cavity. Yes, very good. IVC, inferior vena cava is there. Then thoracic duct is there. Azygous vein is there. Hemiazygous vein is there. Okay. So these are the structures which are ascending. Okay. So when it will ascend, some structures are descending. For example, esophagus is there. Then aorta is there. These are descending. So for that, it has to there has to be some opening. If the openings are not there, then those structures cannot go downwards or the structures can't go upward. Okay, that's why multiple openings are there in the diaphragm. Now those openings are categorized into 2 divisions. What are they? Major openings and minor openings. Okay, so how many major openings are there? 3 major openings are there. Okay, now among them, you can see first is the aortic opening, which is osseo-aponeurotic, and where it is situated? It is situated at the lower where these openings are situated. Okay, so from this opening, the major structures are passing, along with that some minor structures are also passing, that you have to know. Okay. Next, here another beautiful diagram is there where you can see the minor openings of the diaphragm. Okay, So major openings, how many major openings are there in the diaphragm? 3 major openings. Always keep that in mind. Okay. Multiple minor openings are there. Now in order to understand the minor openings, you have to understand the origin, okay, which already we have discussed. So there are certain gaps, okay, on the anterior aspect, there are certain gaps on the lateral aspect, that also from the origin, okay. There are certain gaps on the anterior aspect, gaps on the lateral aspect, and gaps on the posterior aspect, okay, and from those gaps the minor structures they are passing, okay. Now can anyone tell me which is the anterior aspect and which is the posterior aspect over here? So this is the anterior aspect, okay, this is the posterior aspect, because here you can see the lumbar vertebra are there. So lumbar vertebra, we know vertebral column is situated posteriorly, and here you can see this is the xiphoid process, so that will be the anterior aspect, okay. Like this you can easily identify which is the anterior aspect and which is the posterior aspect, okay. Now here you can see some gaps are there, okay, see the gaps are present, okay, anteriorly. Then you can see some gaps are present laterally. So यहाँ पे क्या रहता है, we know the ribs are present over here, okay, that means the fibers are taking origin from the ribs. So there also some gaps are there. From those gaps the structures are passing. So those will fall under minor openings, okay. Next you can see on the posterior aspect also some structures are passing. So these are also minor opening. So in order to understand the minor opening, as I said, you have to go from anterior aspect and then you have to come posteriorly. Once you are coming posteriorly, you have to see the lateral aspect also. Then you can understand the minor openings, okay. Now here on the anterior aspect you can see superior epigastric vessels are there. These are the superior epigastric vessels. Then if you go laterally, then you can see lower 5 intercostal nerves and vessels. You can see these are the lower 5 intercostal nerves and vessels, okay. Then if you go posteriorly, then here you can see subcostal nerves and vessels, okay. Next posteriorly you can see the sympathetic chain also, okay. So like this you have to identify the structures, then it will become easy, okay. And of course the diagram is very important, because if you know the diagram, by looking at the diagram you can write the minor openings, okay. Now there is a chart, okay, and in this table you can see all the major openings, okay. Now one thing which you have to know, that is the action of the diaphragm on those major openings. Action of the diaphragm on those major opening when the diaphragm is contracting. We know that it is made up of skeletal muscle, okay, so the contraction relaxation is there. Now as I said, 3 openings are there: vena cava, esophageal and aortic, okay. At which level they are lying? At the level of 8, 10 and 12 thoracic vertebrae, okay. Now where they are situated, either on the midline or on the right side or on the left side, that already I have shown you. Now here you can see the shape of the opening, okay. Now in case of vena cava it is quadrilateral, in case of esophagus it is elliptical, and in case of aortic it is rounded in shape, okay. These are the different shape of the opening, major openings. Next, structures passing already we have discussed. Now effect of the contraction. So when the diaphragm will contract, then what will be the effect on the opening? Now if you see the vena cava opening, it will dilate. Dilatation take place, so that more venous return can take place. Next, here you can see esophageal, it will constrict the esophagus when the diaphragm will constrict. And in case of aorta, no changes, okay. That also you have to know for MCQs. Okay, next minor openings. So already I have shown you the minor openings, okay. So how we will study? We will go from anterior to the posterior by lateral aspect. Then you can see the different minor openings, okay. Now first, if you see a minor opening which is present anteriorly, that is called a space of Leary, which is a triangular gap present between the sternal origin, okay, and from the 7th costal cartilage, okay. That means anterolaterally, sternal origin and the 7th costal cartilage, in between that on both the sides, small triangular space is there, that is called a space of Leary, okay. Now if the space is enlarged, then it is called as foramen of Morgagni, which is a congenital anomaly, okay. Small triangular space is present, which is normal. If the space is enlarged, then this is a congenital anomaly, and that is called as foramen of Morgagni. Okay. Now from this particular space, it transmits superior epigastric vessels and few lymphatics from the liver. Okay. Next, this is anteriorly mainly. Then if you go laterally, then you can see between the digitation of the costal origin of the diaphragm and the transversus abdominis. Okay, there a space is there, and from that space, lower 5 intercostal nerves and vessels are going downwards. Okay, which will go and supply mainly the skin of the abdomen, muscles of the anterior and lateral abdominal wall, etc. Next, between the costal origin of the diaphragm, 7th and 8th costal cartilages, from where we are getting the musculophrenic vessel. Okay. Next, behind the lateral arcuate ligament, we are getting the subcostal vessels and nerve. Okay. Behind the median arcuate ligament, mainly we are getting the sympathetic trunk. Okay, least splanchnic nerve, etc. Next, the each crus of the diaphragm is pierced by greater and lesser splanchnic nerves. Okay. So these splanchnic nerves are the sympathetic nerve, preganglionic sympathetic nerve fibers, okay, which will mainly supply the various part of the abdominal organs. Okay. And along with that, the left crus which is there, it will directly pierced by the hemiazygous vein. Okay. So these are some minor openings. Now for minor openings, as I said, this diagram is very important. Okay. If you see this diagram, okay, all the minor openings are listed. So along with the help of the diagram, you can understand where the minor openings are situated and what are the structure passing through that minor opening. Okay. So if you see the list, first we have seen the origin, we have seen the insertion. Okay. Now origin insertion is done. Okay, origin insertion is done, and we have seen the major minor openings. Okay. Next will be the actions of the diaphragm. If any skeletal muscle is there, actions are also there of the skeletal muscle. Okay. Now what are those actions of the skeletal muscle? Now in the actions of the skeletal diaphragm, the actions are taking place in 3 particular areas. What are those 3 areas? First, the actions are taking place in the thoracic cavity. Next, actions are taking place in the abdominal cavity, and then actions are taking place in the major openings of the diaphragm. So, what are the actions taking place in the major openings of the diaphragm that we have discussed? Okay. Next, we have to know about the action of the diaphragm in thoracic cavity. So, we know that diaphragm is the chief muscle of inspiration. Okay. Now, what is the mechanism? What happens? When the diaphragm contracts, at that time what happens? Which diameter increases in the thoracic cavity? The vertical diameter. Vertical diameter of the thoracic cavity increases. Okay. Now, if you see the actions of the thoracic cavity of the diaphragm, okay. Now, when it contracts, the lower ribs will get fixed. Okay. After that, what will happen? The vault of the diaphragm descend, and as a result, the vertical diameter of the thorax will increase. Okay. So, whenever the diaphragm is contracting for breathing, whenever you are breathing at that time, what happens? The vertical diameter of the thorax increases first. Okay. Next, what will happen? The upper abdominal viscera are displaced below and accommodate on the anterior abdominal wall. Okay. And as a result, there will be bulge in the anterior abdominal wall. Whenever you are breathing, I hope you have noticed that there is a bulge in the anterior abdominal wall. Okay. So these phenomena are sequential. One after one, it is taking place. Now, when the limit of the bulging is reached at the maximum, the central tendon become fixed. After that, on contraction, further contraction, there will be elevation of the lower lips, thereby anteroposterior and transverse diameter of the thorax will also increase. Now, particularly in this movement, the intercostal muscles are also working. Okay. As a result, what will happen? The anteroposterior diameter, vertical diameter increases. As a result, more space is created inside the thoracic cavity, so that the air can go in. Okay. So this is the action of the diaphragm in the thoracic cavity. Okay. Now, if you see the average range of movement of the diaphragm in quiet breathing, means normal breathing, at that time it is approximately 1.5 centimeter. Average movement of the diaphragm in quiet breathing. means in normal breathing it is approximately 1.5 centimeter, the movement. Okay, now here you can see the movement of the diaphragm, okay, inspiratory movement. Okay, so as it will go downwards, the vertical diameter will increase. Then you can see the lower ribs, okay, they will move laterally so that the transverse diameter will also increase. As a result, the space in the thoracic cavity increases so that the more air can go in, which already you have studied in the respiratory movements. Okay, next, if you see the range of the movement of diaphragm in deep breathing, it is approximately 6 centimeter to 10 centimeter. Deep breathing, okay. In quiet breathing, approximately 1.5. In deep breathing, it reaches 6 to 10 centimeter. Next, the total surface area in adult diaphragm is 270 square centimeter. Okay. Now, among the 500 ml of tidal air or the tidal volume which is entering the lung, among them 400 ml is drawn into the lung, okay, by the action of the diaphragm alone. That's why it is also called as the principal muscle of inspiration or the main muscle of inspiration. Okay. Next, on the abdominal cavity, so what is the function of the diaphragm in the abdominal cavity? It will compress the abdominal viscera and it will increase the intra-abdominal pressure. Okay, it will compress the viscera and it will increase the intra-abdominal pressure. Okay, as a result, what will happen? Which helps in vomiting, micturition, defecation, etc. While doing these activities, the diaphragm helps. So this is the function of the diaphragm in abdominal cavity. Okay, so please note that the functions of the diaphragm in thoracic cavity is different and in abdominal cavity is different. Okay, so you have to understand between the functions. And regarding the major change openings, already we have discussed what are the changes or what are the action of the diaphragm in the major openings. Now there are some postural changes also. That means when the posture changes, okay, the movement of the diaphragm also changes. Okay. Now if a person is in standing position, okay, relaxed position, at that time if the contraction is there, then the vertical diameter increases, which is good for respiration. Next, it is more better when the patient is in supine, that also in recumbent position. In recumbent position, the patient is lying and the foot part is raised above. Okay, you can see foot part is raised above. So this is also good for inspiration. Okay, that particular position. Now there is a position. Suppose if a patient is lying on a particular side, at that time you can see this particular part of the diaphragm is rising upwards and this part is going downwards when the patient is lying on side, either right lateral or left lateral. Okay, so as a result, what will happen? This particular area, the lung which is there, okay, will get less air as compared to this particular side. Okay, so it is advisable to the patient that if the patient is having any problem in the lung, so he or she should not lie on a particular side where the problem is there. Okay, because that will affect the respiration. Okay, so these are the effects of the diaphragm on various posture, whether standing position, lying down position, or lying on the side. Okay. Okay. Next is the blood supply of the diaphragm. Okay, so diaphragm is a skeletal muscle. That means it needs blood supply and nerve supply. Okay, so what do you think? What will be the blood supply? Mainly two sources are there which is supplying blood to the diaphragm. What are they? These are the musculophrenic artery and pericardiophenic arteries. Musculophrenic artery and pericardiophenic artery. These are the branches of internal thoracic artery. Okay. Next, along with that, it is also supplied by lower 5 to 6 posterior intercostal arteries. Okay, lower 5 to 6 posterior intercostal arteries. Next, the superior phrenic artery is also supplying, which is the last branch of the descending thoracic aorta, and inferior phrenic artery, first branch of the abdominal aorta. Okay, so these are supplying blood to the diaphragm, as you can see in the diagram. So this is the diaphragm. Okay, you can see the musculophrenic artery, you can see the pericardiophenic artery, mainly supplying the diaphragm. Next, you can see the superior phrenic artery and inferior phrenic artery. Okay, so superior phrenic artery is the last branch of the thoracic aorta, inferior phrenic is the first branch of the abdominal aorta, and along with that lower 5 to 6 posterior intercostal vessels will also supply the diaphragm. Okay, and the venous drainage directly it will drain into the systemic vein, that is into the IVC. Okay, next the nerve supply. Now in case of nerve supply of the diaphragm, okay, Arif, what is this? This is not allowed, please leave the classroom. From beginning, I have seen, from the beginning you are writing something, that also wearing headphone. This is not accepted. Please don't give his attendance, or attendance aske debe na. Please leave the classroom. This is not accepted. No, how many times I have to tell you guys? Just now Sandeep sir told that you have to be punctual. Okay, the various organs, in that organs we have seen sympathetic, parasympathetic, all those things. But here, though it is a muscle, it is not an organ. So what will be the nerve supply? Motor and sensory. Okay, motor supply and sensory supply. Okay, motor for the muscle, sensory means if any sensation are there, okay, that has to be carried. For that sensory supply is there. Okay. Now, in case of motor supply, it is completely from the phrenic nerve, which already you have studied in case of brachial plexus. Okay. What is the root value? C3, 4 and 5. C3, C4, C5. This is the root value for phrenic nerve, which is motor to the diaphragm. Okay. Two phrenic nerves are there, either side, right side and left side. Okay. Now, see, there is a unique property of the nerve supply, that it will pierce the diaphragm and then it will ramify on the abdominal part, and then it will supply the muscle, not from the thoracic aspect. Okay, it will pierce, it will go to the abdominal aspect of the diaphragm, and then it will supply the diaphragm. Okay, motor supply for the fibers. Okay. Next, the right phrenic nerve supplies the right part of the diaphragm up to the right margin, and left phrenic supplies the left part of the diaphragm up to the left margin of the esophageal opening. Okay, this is the division of the right and left phrenic nerve. Next, sensory supply, you can see central part again by the phrenic nerve, and the peripheral part which is there, that is by the lower 6 to 7 intercostal nerves. That is the sensory supply. Middle part is the phrenic nerve, and the peripheral part is done by the lower 6 to 7 intercostal nerves. That is the motor supply. Okay. Next, as I said, there is a twist. There is an additional nerve supply to the diaphragm. Okay, here you can see the phrenic nerve, this is the right phrenic nerve, this is the left phrenic nerve, which is supplying the diaphragm. Okay. Now, the phrenic nerves, you know, it is also supplying the pericardium also, right? Then it is also supplying the some part of the crura, diaphragmatic crura, mediastinal crura. Already you have studied. Okay. So this is the diagram showing the nerve supply of the diaphragm. Okay. Now this is very important. Okay. Everyone, please listen it carefully. There is a interesting phenomena which is related to the diaphragm. That is called as Orbeli phenomena. L. Orbeli, a Russian physiologist, discovered this particular phenomenon. Okay. Now, according to this, the diaphragm is also having sympathetic nerve supply. According to that particular scientist, the diaphragm is also having a sympathetic nerve supply, which is coming from the celiac plexus. Okay. From the celiac plexus, we are getting inferior phrenic plexus around the inferior phrenic artery. Okay. And then it is supplying the diaphragm. Though it is having sympathetic nerve supply, that's why the muscle don't need to get fatigued. Okay, because as I said, continuously you are breathing, you can't stop your breath. Continuously you are breathing, and we know that diaphragm is made of skeletal muscle, but it is not getting fatigued. If it is getting fatigued, if it is stop working, what you will do? Can you breathe without diaphragm? No, you can't breathe without diaphragm. Okay, so that's why an interesting phenomena which is related to that, it is the Orbeli phenomena. And as I said, L. Orbeli, okay, Russian physiologist, have discovered this particular phenomenon. Okay. Now, according to that particular scientist, the diaphragm is having additional nerve supply. Okay, that is from celiac plexus, sympathetic division. Okay, and it comes from the inferior phrenic plexus. Now, what is the effect Okay, what exactly takes place? Now you can see this effect is thought to be mediated by release of norepinephrine. I hope you have heard about norepinephrine. Okay, rather than direct sympathetic innervation of the muscle. Now sympathetic stimulation of the skeletal muscle leads to release of norepinephrine, or also known as noradrenaline, which plays an essential role or important role in reducing the fatigue. Okay, now because of the secretion of this norepinephrine, what will happen? It will enhance the muscle performance. How it will enhance the muscle performance? It will increase the blood flow, provide more oxygen to the muscle fiber, which will improve the efficiency of the muscle contraction. Okay, as a result, it will delay the onset of the fatigue during the prolonged muscular activity. Okay, so this is how the Orbeli phenomena is preventing the fatigue of the diaphragm, so that we can breathe easily, and that is because of the sympathetic nerve supply. Okay, clear about the sympathetic nerve supply and the Orbeli phenomena? Okay, so that is all about the gross structure of the diaphragm.